Bradycardia.
And that's not one of the answers.
Low heart rate.
We're here. So what's bradycardia? Go back to thinking about what the words all mean to you.
Slow
Heart rate.
Slow.
Okay, is it a normal heart rate in that it's rhythm, that it has all the different parts of the P, Q, R, T, S,
Sure.
A, B, C?
Yes.
Okay,
Yes.
so the only problem is that
Yeah.
it's slow. So it's sinus rhythm, it's just slow. So where would this problem originate?
And the T waves.
And the SA.
In the SA, because it's not sending the signals fast enough. Absolutely. The origination is up here, because the rhythm is all correct. So that's not the issue, it's just the speed. The only thing that controls speed is the pacemaker of the heart. So the SA node is not sending the signal out fast enough,
So the tachycardia occurs there too.
sending out too much signal. Or the SA node, yeah, it's sending too much signal and the AV node is not slowing it down, because the AV node slows down the SA node. Because this beats at about 60 to 100 times a minute, this about 40 to 60, and there you average your 60 beats per minute, your 80, whatever it's, 80 beats per minute. Do the math. That's not my thing. The nurse is caring for a patient who has been diagnosed with elevated blood cholesterol. The nurse is aware that the plaque in the inner lumen of the artery is composed chiefly of what?
Calcium.
What's the plaque inside arteries mostly made out of? Is it lipid and fibrous tissues, white blood cells, lipoproteins, or high-density cholesterol?
Cholesterol.
One.
That's the only one that
Number one.
Lipids.
Okay, well, I've got two people here telling me that it's the lipids and the fibrous tissue. Why?
Lipids
Because
are
it's fat
fat.
building.
It's fat buildup, and then on top of it, the fibrous tissue attachment makes the clots that causes coronary artery disease. So yes, it's a lipid and fibrous tissue. Lipoproteins are in the cell membranes. You are caring for the adult patient who has symptoms of unstable angina during admission to this hospital. The most appropriate nursing diagnosis for the discomfort associated with angina is what? Your nursing diagnosis, what is going to be? You've got a patient with angina. What is your nursing diagnosis? What's happening in angina?
Chest pain.
Chest pain.
Yeah, but what's happening to the
Ineffective
heart? What's it doing?
Cardiac.
You've got constriction. You have a coronary artery restriction that's causing decreased blood flow to your heart. So, what is your nursing diagnosis? Ineffective
Cardiac.
Coronary.
cardiac.
Cardiac.
What's not going to the cardiac muscle? Blood. So what do we call that? Perfusion. Ineffective cardiac perfusion secondary to cardiac artery disease, as evidenced by chest pain. That's how we know. If they have chest pain, we know that that's why. Family members bring the patient to the emergency department with pale, cool skin, mid-sternal chest pain, unrelieved with rest, and a history of coronary artery disease. What is the nurse aware of? Is the nurse aware that these symptoms indicate angina and should be treated as such? That the symptoms indicate anxiety and should be treated as such? That the treatment should be held until an ECG is completed? That the symptoms indicate coronary artery episode and could be treated as such? Okay, well, the patient has a history of coronary artery disease. So he is most likely having an episode of coronary artery disease, and you need to treat it as such before you diagnose that they're having angina. Should never treat it as just anxiety, blow them off. Okay, and we start treating even as we're applying the ECG, and the first treatment is usually we start with oxygen. The patient with angina is beginning nitroglycerin. Before administering the drug, the nurse informs the patient immediately that after administration, the patient may experience what? What happens right after you give them nitro? Big one that you got to tell them so they don't freak out if they've never had it before. What's nitroglycerin going to do for this patient?
Oh, relief.
the chest.
Well, it's gonna be, okay, but that's a good thing, so if we're warning him about something, it's usually something that's not pleasant. So, nitroglycerin is a powerful vasodilator,
So fast.
okay?
False heart rate?
Well, they might not necessarily be aware of that, so we would be monitoring that, but they may not necessarily be aware of that. So when you're vasodilating, it's not just gonna vasodilate the heart, it's gonna vasodilate a lot of other body parts. So what else might happen? They actually end up with a headache because you rapidly vasodilate the head, so the head fills up with blood very quickly, and it just kind of causes like a pressure feeling. And they complain of a headache and even dizziness because you have this rapid dilation, but they've been very constricted. Okay, so a headache is a big secondary symptom to giving nitro. Has anybody ever given nitro or no patient? Have anybody ever complained of that? No? Okay. A 48-year-old male presents to the emergency department complaining of severe substernal chest pain radiating down his left arm. He's admitted to the coronary care unit with the diagnosis of MI. What nursing assessment activity is a priority on admission to CCU? You're admitting this cardiac patient. What's one of the first things that you're going to do for this patient? EKG. Put him on an EKG. Yeah, you want this patient monitored, absolute 24/7. You don't want a minute off the monitor because you're watching for any other activities. So obtaining informed consent would not be one. Auscultating the lung fields, you'll do it. But after you've got that EKG on them and determining if the patient smokes, yeah, again, that would be afterwards. That was probably, if you're admitting him to CCU, that's already been done down in the ER where they've come in from. Oops. Okay, now my bottle's messed up. The patient with cardiovascular disease is being treated with Norvasc, a calcium channel blocking agent. The nurse is aware that calcium channel blockers have a variety of effects. What is one of the therapeutic effects of calcium channel blockers? And if you don't know these answers about these drugs, you have to go back and look at them, but they decrease the workload of the ventricles, okay? So go back and look at your calcium channel blockers and their effects. When discussing angina pectoris secondary to atherosclerotic disease with a patient, the patient asks you why experiencing chest pain with exertion. The nurse informs the patient that exertion does what? You have hardening of the arteries, atherosclerosis. What is exertion doing? It does it anyway. It's just that they feel it more than the rest of us. What does exertion do? Hemodynamically. Okay, who works out? Who goes to the gym every now and again? Huh?
Rapid breathing?
A rapid breathing, which means what? Why are we breathing faster when we do any activity that is more than sitting in the chair and falling asleep while I'm talking? Okay, so the heart rate is now beating faster. So what is the heart rate demanding of the lungs?
More oxygen.
Increased oxygen. So that's why this patient is having some problems with his atherosclerosis and feeling some chest pain because the heart is being exerted. It is demanding more oxygen. And if you have hardening of the arteries, you can't get that blood to those cells and giving them the oxygen that they're demanding, so they're feeling some discomfort. So they're having chest pain.
So basically the answer is they're demanding more oxygen.
The heart is demanding more oxygen during exertion. When assessing a client diagnosed with angina pectoris, it's important for the nurse to gather what information. What's the most important thing once you've got the patient stable that you might want to know? If they've had a history, or what happened right before this? What if there's a precipitating event? Did something happen that caused the angina to kick in? So that would be an educational tool about how to prevent it in the future. What were you doing before this happened? A patient with rheumatic heart disease is at risk for bacterial endocarditis and has been instructed to take what medication prior to any dental work? Antibiotics, definitely. Yeah. They still do that. Some people don't, but they still do that. A patient newly admitted to telemetry unit is experiencing progressive fatigue, hemoptysis, and dyspnea as a result of pulmonary venous hypertension. What valvular disorder would cause pulmonary and venous distension? Think about the two valves. We'll work it backwards. You got one here, A and B. I'm too lazy to write it all out. Okay, so the lungs, blood's going this way to the lungs. Coming back from the lungs here, right? Going to the body. I'm not an artiste. Okay, so you've got a patient who's got fatigue. What's happening during fatigue in a health-related situation? What are you lacking besides nutrition? Oxygen. Okay, so now we know if we're lacking oxygen, it's either heart or lungs. Okay. Hemoptysis, what does that mean?
Speeding up blood.
Spitting up blood. So now we definitely know our lungs are involved. Okay, because that's the only place that we can be spitting up lungs. Something's happening in the lungs. Okay. Dyspnea. Shortness of breath, difficulty breathing, dyspnea, difficulty breathing, as a result of pulmonary venous hypertension, got high tension. So which valve is going to be involved? Mitral valve. Okay, this is how you figure it out. If you can't figure it out, draw yourself a picture and figure, again, I keep telling you, circulatory system, the heart, is kind of like plumbing. If you figure out where the stoppage is, something that's narrowing, something constricted, something stenotic, and follow it backwards, okay, that's going to tell you where the problems are. So in this way, if you look at the symptoms, okay, what's going to cause that? Okay, so that is your mitral stenosis. There's a problem with the mitral valve, look at what's going to happen. Okay, so that's your mitral stenosis. If it was prolapsed, stenosis means narrowing, right? Prolapse means it's falling in here. So are we really going to get backflow, or the problem's going to be outflow? Outflow. Yeah, outflow. It's a slightly different symptomology. So we're running out of time. Okay, patient has been admitted with endocarditis. What does that mean?
Inflammation around
The heart. The patient asked the nurse how the doctor knows the medication to order to kill the bacteria. The nurse knows that to find the most appropriate antibiotic treatment, what test would be most helpful? Get an infection around the heart. What test are we going to do that is most helpful to diagnose infection?
Stress.
What kind of culture? Okay, bacterial culture from where?
somewhere.
Yeah.
Spinal blood.
This is bacterial endocarditis. We decided they've got an infection in the heart.
Yeah. You want to
Okay.
take it out of there.
Okay, so you're going to take a needle, shove it into the heart. Just thinking.
Blood test, yes.
Okay? So we've decided we need a culture, which is a correct answer. We need a culture to find out what bacteria is growing. I'm not really liking her option of putting a needle in the heart. That's just not working for me, because I certainly am not just going to say, sure, shove a needle into my heart. So how else are we going to find out what infection is going around the heart? What circulates through the heart that we can get from other sources?
Blood.
Blood. We'll do a blood specimen. Sure, we're going to do a blood culture. Much easier than a needle in the heart. But I like your directness of approach. Go right to the source. Patient in the cardiac care unit asked the nurse what the symptoms of mitral stenosis are.
When discussing the clinical manifestations of mitral stenosis with a patient, it would be important for the nurse to emphasize what? Just what kind of symptoms are going to have from mitral stenosis? We just did it, ladies.
Yeah.
What kind of symptoms? Are they have a problem peeing?
No.
No fever?
Mitral stenosis, not infection. They just got narrowing of this valve. So what
It's
are,
gonna output the
what's over here that's going to...
hyper,
Okay, so how is the patient going to know?
They're gonna have edema?
Edema would be this side.
Oh, shortness of breath.
Dyspnea, shortness of breath. Yeah, the respiratory status is going to be impinged upon.
yes.
You are receiving a patient with aortic regurgitation from the critical care unit into step down. You're aware that aortic regurgitation may cause what? So
Regurgitation is
here's
out.
like aorta. Okay, we got that aortic valve that's not working properly. Regurgitation means what?
Out.
Okay, well, if it's gastric, it's out. Okay, so yes, you are correct. In the cardiac system, you might think of backwards.
That's not reflex.
It is reflux, but they call it regurgitation because it's just, instead of going forward, it flows backwards, it regurgitates backwards. Okay, so you are correct. I'm just dynamically changing your thought for a second.
Yeah.
So if it's regurgitating backwards, where is it going? What's here? No, we're not back there yet, too far. What's the first place we're gonna go?
But a children can,
There you go. You're regurgitating back into the left ventricle.
what was the question?
Aortic regurgitation, where's it going?
Okay.
Left ventricle. The nurse is teaching the patient diagnosis with aortic stenosis the importance of attempting to relieve the symptoms of angina without drugs. What would the nurse teach the patient to do? So if you're trying to relieve chest pain without drugs, what's the first thing you're going to tell your patient to do? He's feeling chest pain.
Calm
So,
How do you calm down if you feel pain?
because this
Take
is
deep
a,
breath.
deep breaths.
No, it's gonna hurt.
Relax. Because the relaxation will lower your vasoconstriction. You get vasodilation going down. The more you're excited, the more you're constricted. Because when you're excited, what kicks in? Your flight or fight response, which is vasoconstriction.
But how do you calm down if you're in pain?
Because this is a patient that has aortic, what was it, stenosis or regurgitation? Stenosis. This is an ongoing symptomology. It's not the first time that you're feeling angina. It's ongoing. So if you're feeling it, before you take that nitro hit, because the nitro itself has its consequences, including a wicked headache, relaxing. If that doesn't work, the next step is to take your meds. This is the patient education point. People who have mitral valve prolapse may never have symptoms. Other patients with this diagnosis have symptoms. What symptoms might the patient have with mitral valve prolapse? If you don't know, go find out. Look at the symptoms. The nurse knows that the patient has developed a cough, productive cough from mucoid sputum, is short of breath, and has cyanotic hands, and has noisy, moist-sounding, rapid breathing. What are these symptoms of? Noisy, wet breathing, productive cough, mucoid productive cough. What are these symptoms of? You're in your cardiopulmonary system, remember, ladies.
CHF?
Okay? Part of CHF is, instead of just heart failure, because heart failure, you're going to be in edema and all those, back it up to a much more narrow point of view, where you're having just lung symptoms. What do we call that?
Congestion?
Okay, give me the scientific word for that.
Pulmonary edema?
Thank you. Pulmonary edema. Lots of fluid in the lung, wet, goopy cough. Because of the fluid in the lung, your patient's gonna get dusky and cyanotic. Okay? So that's pulmonary edema. Those are your symptoms. You're a nurse working triage in an emergency room, emergency department. A patient with heart failure has presented to the ED. In reviewing the patient's past medical history, what is the primary cause of the patient's heart failure? What is the primary cause of heart failure? The number one.
Heart attack.
It's not going to be a heart attack. It's a long-standing disease process. Causes-
Hypertension.
Hypertension would be one, but it's not the number one that causes heart failure in and of itself, because it doesn't.
Something when it dies.
Atherosclerosis, hardening of the arteries will lead to heart failure. A nurse in the CCU is caring for patients with heart failure who has developed intracardiac thrombus. What is the most common complication of a thrombolytic problem among heart failure patients? If you've got a thrombus, you've got a what? It's another, what's the technical word for that? It is a PE. What does that stand for? Pulmonary embolus. Exactly. You're going to throw embolisms, and it's going to go to the lung. That is your number one. If you have thromboembolic problems, your DVT patients, you're always worrying about a PE, pulmonary embolism. Very good. Good answer. Patient presents to the emergency room complaining of increased shortness of breath. The nurses assess the patient's history, God bless you, and notes that they have left-sided heart failure. The patient is agitated, coughing up pink, frothy, foamy sputum. Watch the nurse recognize these signs and symptoms of. These are classic symptoms: pink, frothy sputum. Any- Okay. You've got shortness of breath. You've got left-hearted heart failure. Okay. So this is not working. So what's going on with our circulation? It's backing up this way, and then where is it going? Okay. So now we have shortness of breath, wet sounds, pink, frothy sputum. So we go wet sounds, they're not breathing well. What's in there?
Blood.
Well, blood is mixed with, we don't call it water. What's the technical word when you're holding on to water? And what system are you in? So we have acute pulmonary edema. One of the classic signs is pink frothy sputum. They're literally coughing up blood and fluid. Clinical, very, very classic sign of acute pulmonary edema versus chronic pulmonary edema. The
only difference between acute and chronic is the blood.
Then you have the blood in it, a little bit of frothy sputum. It's a big, big symptom. The student nurse is studying the possible complications of heart failure. What would the nurse mean if he demonstrated on the chart that the patient is experiencing orthopnea? Oh, this is supposed to be an easy one. What's
Difficulty
orthopnea?
breathing when they move.
Okay, it's breathing, okay? So we have some options here. It's not, well, if we're having difficult breathing, are we gonna have them walking? So what is one position that we generally do not push our patients when they're having trouble breathing?
Lay down.
So orthopnea might be what?
Lay down.
What laying down?
Difficulty breathing.
Difficulty breathing laying down is called orthopnea.
So the
How did you
question,
piece that together?
wait, yeah, was the question, what is orthopnea?
Yeah.
Whatever? Oh, okay.
Difficulty
How,
breathing laying down.
how did you piece it? Orth means,
Orth is not, orth is just bones usually, but
I know, that's why
orthopnea
I
is
was
breathing down. Breathing, difficult breathing lying down is called orthopnea.
Orthostatic hypotension, when you're down, from down to up, same thing. We have 2 more questions and we're done. The nurse is performing an initial assessment on a client with heart failure. Can you get the theme here that where I'm going? Heart failure, heart failure, heart failure. Because we deal with it so much, you've got to understand this. The nurse also assesses the patient's sensorium and level of consciousness. Why is the assessment of the patient's sensorium and level of consciousness important in patients with heart failure? Celine has 3 answers. I don't know why.
What's sensory?
Level of consciousness, their meditation, how are they thinking? Why is that important?
That's the first thing to call.
Just blood?
Oxygen.
Oxygen. It gives you an idea of what the oxygenation to the brain, the level of consciousness, sensorium. Exactly. Exactly why. The nurse is caring for a patient with pulmonary edema. The patient is receiving continuous IV infusion of vasoactive medications. What would the nurse monitoring the patient? What would the nurse monitor in this patient? Vasoactive agents. All that apply. So what are the things we're going to monitor in a patient on a vasoactive medication? Vasoactive means we're dilating them. So what are we going to monitor on this patient?
Low blood pressure.
We're going to monitor their blood pressure. Either way, we're just monitoring blood pressure for sure. What else are we going to, what did you say, Vicki? Somebody over here said it. I'm sorry. Airway, breathing. Okay, they're going to be breathing, so we're going to monitor respiration, we're going to monitor pressure, and what else are we monitoring? Heart rate, yeah, definitely. So they're probably going to be on a heart monitor, so we're going to be watching that. Yeah, see, that wasn't so hard. Nursing students are studying the cardiovascular system. Guess why I put this question on here?
To torture us.
I said, because you hate us.
Gosh darn. One student asked the instructor, what happens when the amount of fluid in the pericardial sac increases? What should the instructor tell the student? That's not one of the answers, but I can put it in here.
Get it right.
Okay, pericardial sac has an increased fluid. We know the pericardium is supposed to have a certain amount of fluid. Why?
So the rubbing.
So the heart, as the heart beats, does not have friction. Exactly. So now we have increase of fluid in the pericardial sac.
Applies pressure to the heart.
And applies pressure to the heart. Is that a good thing?
No.
Okay, that's it.
What was the question?
What should the instructor tell the students? It applies pressure to the heart. Not a good thing. That's it. It compresses the heart. If it compresses the heart, eventually the heart, the fluid, if you have increased fluid.
No, what's the word that you use?
Cardiac tamponade. Creates cardiac tamponade eventually. And that is it, folks. So now you know pretty much everything that you need to focus on your test.